Hey, good morning, everybody. Welcome to week one, session one for the CHAPS program. So that's the Care Home Assistant Practitioner. So this is the 8-week session for all the clinical skills in which you're going to need for your assistant practitioner. And obviously, once you've completed these 8 weeks, I'm going to come out and observe you in your place of work. So every module in which we cover, there is an assessment. So it's really important that you do attend these sessions. You watch back, make sure you do those additional bits, because when I come out to see you, we're going to be talking about certain things. And at the end of each module, I'll talk to you about what the assessment is. So when I come out to see you, you know exactly what it is you're going to do. So for today, we're starting really at the very beginning of the nursing journey. We're going to be looking at holistic assessments, why we use assessment tools, what assessment tools we're going to be using. We're then going to be moving from there into a bit of person-centered care planning. I know I've done that session before, but we'll just top that up. There'll be a bit about re-enablement, and then we're going to end the day on intramuscular injections, which seems a bit odd that I've lumped that on the end, but it had to come in somewhere because obviously when I come out to see you, I do need to see that you're able to do that. So it's going to feel quite fast-paced. There is a lot to go through today. If you start to feel fatigued or you think, Steve, I just need 5 minutes, drop it in the chat room or just say, can we have 5? And then we'll have a natural break when people start feeling fatigued. I will call, obviously, break roughly around 11:30, 11:15. Then we'll have lunch about 12:30. And then in the afternoon, we'll probably have one around 2:30-ish. So quite a lot to get through. Equally, all of these slides will be uploaded into Canvas, and the video from today's session is going to be uploaded into Canvas. So hopefully by now, I've seen you've all logged on. Under week one, these PowerPoints will be there and these videos will be there. And equally, you're going to need to know that because when we do the professional discussion, this is the theory that we're going to be talking about. So it's important that you are able to go back and reflect on some of the stuff. That way, you don't necessarily need to take notes today because it's going to feel quite fast-paced lecture style, but you've got access to all the information anyway, and you can download those and print them out and you know, get your highlighter pen if you want. That's entirely up to you. So, before I start, is it possible for everyone to put their camera on? Just so I can obviously see people?
Sorry, Stephen, I don't know how to do it.
That's okay if you can't, that's not a problem. Jessica, are you able to put your camera on? Marvellous. It's just useful if I can see a couple of people in the room. Equally, we may have some stragglers coming along because I know some people are going to be attended a bit late today. So we'll just admit them in the rooms. So before we start, has anyone actually conducted holistic assessments? When I use the term holistic assessments, do we know what I mean by that?
Yeah, it's seeing the person as a whole, is not only meeting their needs like food and drink or their path changing, is everything like I'm thinking about Maslow hierarchy of needs as well.
Yeah, so it's the activities of daily living, and like you said, it's seeing the person as a whole. And equally, the way in which we do that differs from service to service, it differs from borough to borough, home to home, hospital to hospital. The reality is, each online software we use have different ways of doing it, but ultimately it all drills down to the activities of daily living. You know, the getting up, the washing, the dressing, the eating, our mental health, our physical health, and then all of that bits underneath around spirituality, etc. It's important throughout that we take into account the holistic view. So we're not segregating physical health and mental health apart, but we're actually putting the two together because there's no health without mental health. And vice versa. And what we tend to find is the two are very much interlinked. So if somebody's physical health is deteriorating, it's going to cause signs of depression and make them feel lower in mood. If we can pick that up, it picks the mood up, and vice versa. If somebody's depressed, they generally are not going to be eating, or maybe they're not going to be moving that much, therefore it affects the physical health. So actually the two are very much interlinked. Okay. So obviously, phones on silent if we can. The register's being done in the background. Tom is in the room. He's under my name called Steve. So he's on there. So if you've got any questions, you can pop it in the chat room. And what we'll do at lunchtime, we'll get back to any questions because it just means that I keep the session rolling. If you have a first aid emergency, I hope you're all able to sort yourselves out. Obviously respect each other, ask questions as we go along. We've already spoken about the breaks, and I do need everyone to participate. So I need you to at least talk once or twice throughout this session because it shows me that you've understood it. Right, so basically, the term holistic means we're looking at the whole person, the body, the mind, the spirit, and obviously we're looking about them being completely engaged. And we're looking about trying to enable people back to full health or back to being able to do skills or tasks they've already done, because that's the reason why they're in care. So either nursing care, residential, social care. And again, it's all about looking at what they can do. So that strength-based approach over anything else. And it may be the case of learning new skills, meeting those resources, and empowering people to do what they can do. So do we think older adults may unnecessarily develop feelings of dependency, uselessness, and powerlessness during times of illness and stress? Do we think that's true or false? So they become passive recipients of care. Do we think that's true or false? What do we reckon?
I didn't get the question, sorry.
So the question's on the screen. So we're talking about older adults may unnecessarily develop feelings of dependency, uselessness, and powerlessness during times of illness and stress if they become passive recipients of care. Do we think that's true or false? So what we're saying there is the older we get, the more dependent we become on people.
Not necessary. If we are supported to do for ourselves things, we can, so it is I think this is what I've read about reablement. Like as much as you put them to do for themselves, just support them, stay in their back and watch them, then they will get that independence after a couple of weeks, let's say, or even less, depends.
So there's models of health out there. So what you're talking about is that enablement model, isn't it? What you're talking about? You're talking about that empowering people. Do we think we do it particularly well in the UK? Do we think we're very good at this?
Yes, we try at least,
We try, we do try. And again, what I need you to do is think outside your homes, because your homes or the services you're in may be very good, but we're looking across the healthcare spectrum. So again, in hospitals, do you think we're good at empowering people in hospitals? Or do we feel that the hospitals are just too overstretched to be spending that additional time to empower people?
Yeah, that one.
Yeah, they are completely overstretched, aren't they? What about residential homes? Do we think residential homes are good at empowering people?
They can be.
They can be, but normally residential homes are quite short-staffed, aren't they? Because the ratio, you don't need as many staff to carers, to patients, sorry. What about nursing homes?
They need a bit of improvement,
It's hard because the problem with nursing homes, they already come with their physical conditions and maybe they're already heading towards end of life and they've given up. So I think this is probably where this statement's looking at. So actually, there is a lot of evidence to suggest that people do become completely dependent. They feel completely depowered. And there is this reliance. The moment you go into a care service, it's that transference of I don't need to look after myself anymore. That's what you're here to do. And that's that model in which I don't know who said it, but that's that model of that enablement model, isn't it? About trying to break that cycle around promoting that independence. Now, we know that there's different factors that affect people's health. So we've got the biosocial model of health. And in the biosocial model of health, we're looking at social, spiritual, promoting mind, body, and spirit, and all of this.
My mum and my
beautiful why we're there. And again, throughout that, it's really important that we're able to identify different parts of that biosocial model. And when we're planning for care, we can look at all of those separately, but bring it together under that holistic approach, which we started to talk about at the morning. Equally, when you do your assessments and in your endpoint exam, you are going to have to talk about a theory of health. So the biosocial model of health is the recognised approved model, because actually it covers the 3 sections quite nicely, and it is a recognised model. Equally, you've got the medical model and the social model. So they kind of come together, but from very different angles. So it's important that when we are planning for health, we're planning across all of the areas. And there's no necessarily right diagnostic tool for this or assessment tool for this. It is down to your service to try and pull that out. Generally, what we call it is an observation. So we do holistic observations as nurses. We observe the person as a whole, and we try to collate all of that information into us. And what NICE guidelines state is it all starts with a clinical interview. So a clinical interview is just a series of questions. We're just going to start talking about their past, their experiences, what's affected them, what's brought them to this point where they're sitting in front of us. And actually, from that assessment alone, you are going to get a huge amount of clinical data and information. And that's what a holistic assessment is. So a holistic assessment tool is a tool that's designed to open up a conversation. Now, equally, in previous sessions, you may have heard me talk about Davis's structured interview questioning techniques. And he talks about 3 things about logging on, maintaining a conversation, and logging off. So logging on to a clinical assessment is, what's the most important thing I can do for you today? What brings you here? How can I help you now? What's the now? Because people want to be heard. Then we do the bit in the middle where we're going to ask a series of questions, and then we're going to log off at the end. And whenever we log off, we always say, is there anything else you want to tell me? Because again, people may have missed that opportunity to tell you something that's vitally important, or it's not on your checklist. So it's really important that we log on. What can I do today? What's the most important thing today? Ask your series of clinical questions, and then we log off. Is there anything else you need to tell me? What else can I do for you? Because it gives that opportunity. And when we look at NICE guidelines, because we're evidence-based practitioners, that's where we need to be getting our clinical information from. They're the guidance in which you're going to be told. So it's really important we follow that structure when we interview. Equally, as we go through the assessments, we're going to be looking at opportunities for health promotion. And health promotion could be really simple things in which we can do to promote people's health and well-being. So, for example, what's the importance of brushing your teeth in healthcare? Why is it important we brush our teeth?
To have a healthy
teeth and gums. Yeah, absolutely. One, to have healthy teeth and gums. So if we don't brush our teeth, we can end up with gum disease. We can end up with teeth falling out. It can be difficult to eat. We can get infections. That can cause weight loss. And actually, that one simple task can trigger a whole heap of problems, can't it? What else happens if we don't brush our teeth?
Teeth can fall down.
Yeah, so we're going to have dental problems. Has anyone seen the latest research? It came out last year regarding the plaques, the enzymes and plaques in our gums, what it does to our brain. Did anyone read that last year? No, it's okay if you haven't. So there was a research done last year, and what it has identified is people with poor oral health are more likely to get dementia, because the bacteria in our gums affects the protein in our brain and builds stronger proteins. So actually, brushing teeth is a real health promotion, not only just for gum disease, but to stop other long-term illnesses, such as dementia. Equally, we've got infection and all that lot. So as we're going through this holistic assessment, we're looking for natural opportunities to do health promotion, because health promotion is a cheap and effective way of stopping poor health conditions and blocking up the NHS or hospitals or making things worse. Can anyone think of other health promotions that we can do which doesn't cost anything but has a long-term benefit? What else could we say about health promotions?
Hand wash.
Hand washing, yeah, brilliant. If you go to the toilet, before and after, hand wash, because absolutely, we've got all of that infection and all of that lot. Anything else? Think about the government, what they constantly push on TV. What do we do on that? What do they constantly push on TV?
Maintain a good
I know you're there.
weight, a good weight.
Yeah, so the healthy eating. So we've
Yeah.
done that veg campaign, haven't we? Eat
Yeah.
5 a day. Okay, if anybody can actually do a research project on this, so you know how you've all got your research project. This is a research project in itself. How many fruit and veg do you need to eat a day to be fit and healthy? So the government say 5, it went up to 7. There was a recent thing that said 10. To be fair, I'm all over the shot in it. I don't know how much fruit and veg we're meant to eat a day now to be healthy, because the guidance keeps changing. But equally, we know that if we eat a reasonable amount of fruit and veg a day, what does that do to the body? What does it promote?
Good health.
Promotes good health, but think about the organs and the anatomy and physiology.
They work properly.
Yeah, so exactly. So if we eat a good proportion of fruit and veg, it stimulates cell repair. So if we've got patients that have got pressure ulcers or wounds, putting them on a high fruit and veg diet will stimulate cell repair and actually improve their chances of healing. So again, not having to use all these really expensive Manuka honey bands and all of this wound dresser stuff. A simple diet could improve somebody's health and well-being. The problem that we have, or we seem to have in the UK, should I say, is we're not very proactive. We're more reactive. We only deal when there's a problem in front of us. We don't seem to do very well at stopping the problems, but we're very good at dealing with the problems. And the reality is, when we do our health assessments, we should be looking at all opportunities to stop further problems. And we also know a good balanced diet will help with diabetes, helps with pressure and wound stuff. So there's a massive evidence there to say, you know, this is why we should be doing it. So health promotions, when we look at your professional discussion and we're looking at cost-effective solutions, health promotions is the cheapest and best cost-effective solution to promote people's health and well-being. We've got smoking cessation to stop smoking. We've got reduce your alcohol intake for liver and cell repair. We've got the veg campaign. We've got the immunisation and boosters campaign. We've got the flu vaccination campaign. We've got the COVID campaign. So all of this stuff stops long-term health problems. And as we do an assessment, we naturally could be going through all of this, and all of a sudden your knowledge to provide safe health and well-being is doubled, because actually that bit of advice and guidance can go a long way. When we give a patient information, advice and guidance, it's called psychoeducation. So it's a nursing term. So psychoeducation is me as a nurse passing on this information. So I'm not prescribing it to you. I'm not telling you you must do it, because that's a medical model and we don't necessarily work under that in health, because we're all about promoting rights and choices, aren't we? But what we can do is we can talk about the risks. You know, if you don't eat your 5 fruit and veg a day, there's a chance that your cell repair won't be so good. If you don't eat your 5 fruit and veg a day, there's a chance that you could become diabetic and that could have a long-term effect. But we can give them those choices, can't we? Because actually part of our assessment isn't just taking information, it's giving it back. So the more we know about government health promotions, we know they're evidence-based, we know they've had lots of research and funding put behind them, and we know that they're simple strategies to improve health and well-being. Any questions on health promotions? Happy with that?
Yeah.
And the reality is, now you're hearing about health promotions, you will be surprised how many there are out there, how it's constantly being fed through media, and we don't realise that they're coming, but they are there. So what do we think about this statement? The definition of health is the absence of disease. Do we think that's true or false?
I think it is false.
We think it's false?
Because it is important, the relationship with ourselves and with others as well.
Yeah, I would probably agree with you there. So health is health and well-being. It's not just the physical, it's the mental as well. So there we go. It's false. And again, it is the case of taking it beyond just seeing what's in front of us. And it's that holistic approach, isn't it? And when we look at communication and when people have an inability to communicate clearly to us, it's about us trying to find out what the meaning is behind what's going on. So the reality is you may have a patient in front of you, and in the back of your mind, you're already doing the assessment. And I'm sure if any of you have been in a situation where you've done assessments, you've kind of got it all in your mind why this person's in front of you. The reality is sometimes what you see and what they tell us don't necessarily tally up. And what we have to do is dig and pull. For example, I've done many assessments on people who are obese. And I say to them, what is it you're eating? And the first thing they say to me is, I don't eat much at all. Now we know, ultimately, you don't get to being obese if there's not an underlying problem. So is it the fact that you're not eating that much at all? Do you have an overactive thyroid? Or are you on medication that's inflating you? So I'm not going to prejudge, but there are some medications in which you can gain weight. So lots of the antipsychotic medication, you can balloon. You don't need to, you can eat a biscuit and next week you're the size of a house. And I've seen that done many times in forensic wards, especially with women who take some of the stronger medications like haloperidol. If they take that, they just gain weight. They don't need to eat anything. We would then judge them and go, well, you're obviously the size because you're overeating. And actually, that's not the case at all. So it is the case of looking beyond what we see, asking those questions, and then forming the judgment. The problem is what we do in healthcare, we already start to form our judgments before we see the person. And actually, that's an unfair thing to do. And I know you're all going to go, oh, I wouldn't do that. But we do that. We all do that. We all judge somebody within the first 7 or 8 seconds of meeting them. So the reality is we just have to look at our own values, our own beliefs, our own systems, park it. And really, when we are talking to somebody, we just keep digging. Now, have you all heard of the root cause analysis, the 7 whys? No? So when we interview somebody, if we want to get to the bottom of a problem, we ask why 7 times. And what happens there is, it means you can keep digging and digging and digging until you get to the root cause of the problem. So for example, if I said, why are you smoking? I enjoy it. What does it do for you? Well, it helps me with my stress. Actually, so that's one of the problems, isn't it? So why do you get stressed? Oh, I've got a hectic home life. I've got this, and this going on. Okay, so that's another problem. And actually, as we keep unraveling that wrapper, we can start to get to the bottom of the problem. And what we can then do, we can say, well, actually, if we start addressing all of this at the bottom, we can help the surface. But there's no point putting a plaster on a massive open wound because we need it to heal from bottom up, don't we? And the reality is, in healthcare, what we tend to do, we only treat what's in front of us. We don't like to dig deep. And actually digging deep helps you find out what somebody's thinking. It helps you find out what they're feeling, and it gets to the root cause of the problem. And equally, as nurses, when you supervise your staff, the root cause analysis, the 7 whys work a wonder there too. So if you've got a member of staff and you've just seen them do something silly, maybe they're not turning up on time, maybe they're back chatting you, maybe they didn't provide really good care to your customer, the people you look after, you could ask them, that was an interesting thing, why did you do that? They'll tell you. Interesting, why did you do that? And actually what you start to get is where they're coming from. And then you can understand what you need to do to repair relationships. So root cause analysis, interviewing skills is really important when we carry out assessments. So those 7 whys. Now we know that there are lots of health challenges, and the health challenges are completely outweighing the number of staff we have, the number of services we've got, but equally we have to get ourselves to a position where it's being sustained. And the problem we've got is we're living longer, and as we live longer, we get more chronic health conditions. And the more chronic health conditions we get, the harder it is for us to manage people's health and well-being. And equally, I think where we're going to see care homes in the next 5 to 10 years is your services are going to be dealing with probably the most complex care we've ever seen in history. Because we're living longer, because we're overcoming more obstacles and barriers, you are going to be faced with such complex care in care homes, because all of the stuff that you're dealing with will be seen to be treated in the community. And I think we're going to see a massive shift, because the reality is, if we look at the long-term health plan for England, we're running out of budget, we're running out of staff. So where do people go? And what that means is we've all got to start to upskill or do better at health promotions or better at assessments to keep people from using services. So it's important that if we do have health challenges, that we understand beneath that comes lots of education. The more the patient knows about their health condition, the more we're able to empower them, which is what somebody said earlier about that empowerment stuff. Can anyone give me an example in your role about how you empower people about their chronic health conditions? So that could be COPD, asthma, diabetes. What do you do in your care services that helps promote that?
Encourage to smoke less if they've got
Yeah, asthma, COPD. Yeah, and that one again is a really challenging subject, isn't it? Because people will argue, but I have the right to smoke. You do, it's an unwise choice. We have to balance that up with your decisions. But equally, it goes back to that psychoeducation. So we could sit them down, have a chat. Look, if you reduce this just by 2 a day, or at least you did a smoking cessation, this would improve your respiratory distress by X amount. Okay, lovely. Does anybody else have an example about how we can use education to promote chronic health conditions? Anyone else? So what about diabetes or strokes or COVID, long-term effects of COVID? Has anyone got any examples there that they could talk about?
I got diabetes, so I can encourage to eat healthy and to.
Yeah, absolutely. And that's a really good example, isn't it? But just encourage them to eat healthily is where you need to be on that. And sometimes if we tell somebody to do something, what are they likely to do? If we say
Opposite, I think.
yeah, they're going to say, don't tell me what to do, it's my life. So how do we get around that? What is it we can do to deal with those health challenges? How do you provide that information in an impartial way to allow somebody to make a full choice? How can you do that?
We can explain to them why they have to do that.
Yeah.
Obviously the choice is theirs, but yeah, we have to explain why they have to do that and what the advantages would be if they will do that.
Okay. Anybody else? Karina, you was going to say something?
Yeah, just to explain to them what the benefits will be, and
Yeah.
yeah, they will become healthier and
Absolutely. So we're being impartial, aren't we? We're saying, look, we get it's your choice. Here's the information, the psychoeducation bit, because psychoeducation relates to the mind and the education is the practice. So the psychoeducation part is, look, if you do this, these are the benefits. You know, if you do this, this is what we're going to hope. This is what we're going to hope it's going to stop. This is what it's going to improve. The reality is we can't tell them, because the moment we tell somebody, don't do that, we go back to our childhood where we become quite defensive. And then we become that prescriber And that's not what we do in nursing. We're not there to tell people how to live their lives, but we are there to give that comfort, support, information, advice and guidance. So it's a really important process. So requirements, yeah.
Can you hear me?
Yeah.
Because obviously we are dealing with dementia. We cannot obviously tell them what they do because we just kind of follow up follow the care plan, what to give, because if they are diabetic, you cannot tell them, but we are just like advising the family not to give, or chocolate or send so much food, because sometimes we cannot stop the family, but they know that the person or the residents are diabetic or have chronic condition.
Okay, so within that situation, so if we talk about dementia there for a moment, because you obviously know that that's my area. The reality is with dementia, we can still give the information, advice and guidance. We can still say to Bert, look, Bert, if you eat that chocolate bar, it's going to push your blood sugar up. We can keep it small sentences. They still understand the now, they just may not be able to retain it. So it is that constant reinforcement, this is going to make you poorly. Granted, at this point, we should have a Doles Act in place or the new LPSs coming in. So we would be able to say, look, we are going to do this in your best interest and restrict you. So it's about having that paperwork to balance the right of depriving of somebody of their liberty. All the time that I've worked in dementia care, we've been able to say to somebody, look, I know you want that chocolate bar, but here's a better option. But you have to have the option ready to go. And 9 out of 10 times they'll take it. It's very rare that they'll stick with what they originally wanted, because you can use distraction techniques, you can do a bit of guiding. But ultimately, it is about capacity, isn't it? And about those long-term effects. So what we would expect to see is a risk assessment done on positive risk taking. So actually, is it really going to harm you if you want that bar of chocolate?
Yeah.
If you want that glass of wine at night, is this just me panicking, or is there enough evidence to suggest that this is an unwise choice? So you would want to see in that planning some real rationales to why we're going to deprive somebody or not deprive somebody. But 9 out of 10 times, even with dementia, you can talk to them. The problem is it takes time. And that's the time that you lot don't have in care homes, because it can take 30 minutes to talk to somebody with dementia about an unwise choice, can't it?
Yeah.
And you probably don't have 30 minutes to sit down and show that level of compassion, because you are incredibly busy people. So therefore, you rely on the mechanisms of the best interests or the Doles to work in favour. And then we go back to the dignity part. Is that a dignified way of treating people, that we're relying on a paper system? And it's a tough one, because we know we don't want to do it. It's the case of this is what the pressure of the industry is. But again, it's that equally could be a research project in itself, couldn't it?
Yeah.
So this is as we go through these modules, it's really useful to have those discussions, because I want you to start thinking about your research topics, and things like this make great research topics. Should we deny Bert his chocolate bar? And I think you'll find it'll come out quite 50-50. And yeah, so it's useful to think. But it's about being realistic, isn't it? It's about setting those expectations. Okay, so another question here. The desire to take action is affected by the value a person seems in forming the action, as well as the person's knowledge, action, beliefs, and motivations. So do you agree or disagree with that? So I think what we're saying there in a nutshell is, based on our own values and our own knowledge and attitudes and beliefs, can we agree or disagree? Can we support somebody to sway? So can we change people?
I think some ways, yeah.
Sorry, you said yes, was that Clara?
I think it was me, Karina.
Karina, sorry, so you said yes?
In some in some of them we can change. them
Yeah.
encourage to.
Yeah, I think I've seen it time and time again where you can go into a room and say, do you want a cup of tea or do you want that Horlicks, which will help you sleep at night? Do you want this or would you rather this? Because that's us using our own values and beliefs, our own knowledge, say, look, this is the right choice for you, but I can sway you. So I would agree there. So again, true, yeah. So the reality is our knowledge, our beliefs, our attitudes do motivate and influence us. If we are a non-smoker, so if we're an anti-smoker, when we see somebody smoke, whether we think we're doing it or not, we're being quite prejudiced towards that person. We're going to go, it's disgusting, you shouldn't do it, it makes you smell, it's bad for you, and we could be quite negative. If we're a smoker, we could be quite sensitive towards that. We could go, but that's their right. They enjoy a cigarette. That's what they want to do in their life. So the reality is, depending on your values and beliefs, would depend on where you stood with a resident smoking. Do we agree?
Yes.
Yeah, I mean, I'm just using that as an example. I was in a care home once and the nurse said to a 98-year-old man, smoking will shorten your life expectancy. He was 98. Yeah, 98 years old. If you carry on smoking, it's going to shorten your life expectancy. And his response was, well, I don't want to live forever. So it's one of those things. It just seemed an odd thing to say to somebody who is 98. You know, he's obviously made this decision. It's obviously something he's done his whole entire life. Had you come up with some more clinical evidence, then maybe we could have got somewhere. But that was because she was an anti-smoker. She absolutely, as the nurse in charge, couldn't bear staff going outside having a cigarette and had a real problem with customers smoking. So again, that alters the values and the beliefs, and we can change people. And that's not what we're meant to be doing as nurses. We're meant to be standing back and being impartial. So basically, when we look at our assessment tools as nurses, when we're doing these clinical assessments, when we're observing somebody, we need a toolbox of assessment tools. And throughout your career, you will get lots of evidence-based assessment tools. And a lot of the online systems in which you use will have some embedded in them, but it doesn't necessarily mean that they're evidence-based, and it doesn't necessarily mean that they've been approved by NICE guidelines. That's what that company has decided to use. And if you are using electronic tools, you should understand where they have come from and how those tools meet NICE guidelines, okay? Because you are going to be using them as the clinician. So what I'm going to do is we're going to talk through some of the most popular assessment tools that nurses and carers use. And these will become things that when you're talking to somebody, when you're observing somebody, you're going to be going, need to use that tool, need that tool, need that tool, need that tool. Because when we do an assessment after the observation, we normally go away and we reflect about the conversation that we've had. From that conversation, so let's say, for example, I've spoken to Louise down in the room and I've gone, okay, Louise seems a little low in mood today. I can see that she's got a bit poor personal care. Maybe I can see a bit of redidary skin. I can see her lips are a bit dry. Maybe she's a bit dehydrated. I can see maybe a bit of poor nail care going on. So in the back of my mind, I might be going, all right, so maybe I need to do a must score. Let's see what her weight is and let's see how that balances up. Maybe I need to do an activity of daily living assessment. Let's see how that works. Let's look at food and fluid. Let's see how that works. And actually, it's down to me to justify why I've picked a clinical tool to that patient. And if something happened to that patient and you are the one that's written the care plan and you've done all the prescribing for that patient, if that patient dies and it goes to coroner's court, it will be you that's held accountable because you were the clinician that did the assessment, picked the tools and did the care plan. So it's really important that whatever you say to somebody, you can back up with an assessment tool, because therefore, when we use evidence-based practices, it's not your opinion. So I wouldn't say, look, I've put Louise on a high maintenance diet because I can see she's underweight. I would say Louise has gone on a fortified diet because her must score was below the normal average. So it's not me, it's not my opinion, this is the evidence that has got to that position. No different to, I'm sure you've all heard of the Waterloo scores. If you've got somebody with a score that puts them at risk, you would put them on the airflow mattress, all this stuff. So we're going to run through some of the assessment tools. Some of them you may have heard of, some of you may not have heard of them. What I will do after today, I'll give you access to my nursing link, and you'll have access to all of these forms anyway. So you can see all of the different forms in which you can use. And I'm more than happy for you to borrow these forms. You can use them in your place work or use them as a case study. But in your endpoint assessment, you are going to be observed probably doing an assessment, or you could be doing a series of vital signs. And in that assessment, you will need to dictate which assessment tools you're going to use and why. Okay, so it's really important you get your mind around all of the different assessment tools. So we'll start on A. So here you can see we've got different ones here, looking at the mental state test, the MMSE, or the mental state or mini mental state examination. And the mental state examination basically is an assessment, and it's a fantastic assessment tool, the mental state examination tool. It basically is a series of boxes in which you fill in on a patient, and it looks at, are they dressed appropriately? So if somebody is dressed not right for the weather outside, that straight away tells you there's a cognitive impairment of some type. Because the reality is, if it's raining outside and somebody's in shorts and t-shirts, does it mean that they've got a cognitive impairment? So they're not aware of what's going on, they're different perception. Is it the fact that maybe schizophrenia, so their hypothalamus isn't connecting properly, so they don't feel the temperature, and actually straight away, you've got something going on there. Maybe they're dressed untidy, maybe they don't look well kept. So all of that data tells you that something's not right. And the mini mental state examination runs through a series of questions. You don't even have to ask a lot of these questions, it's just done by observation. And as you go through that assessment, the mini mental state examination, you will come up with a conclusion that this person either has capacity or you are going to query capacity. You're going to say, look, my judgment is, based on this report, this person is lacking capacity because. Really useful if you're in an A&E situation. So if you're ever working in a situation of accident and emergency, really useful, because you can get them as a tick box or you can get them as boxes that you write in. Okay. So the ABCD assessment, we should all know that from our first aid principles: airway, breathing, circulation, unresponsiveness, disability, etc. So that one, and exposure. So there, we're just looking at our normal respiratory primary survey checks. And again, we do that all the time, don't we? All the time when we go and see a patient, we do ABCDE, don't we? AVPU, our alert, voice, pain and unresponsive, is a nursing assessment tool. It's part of the Glasgow Coma Scale. And in there, again, we're just doing levels of unconsciousness. The ACE looks at, oh, hang on, I'm going a bit too fast. The ACE looks at cognitive functioning. And again, you can use other parts to help this. So you've got your electrocardiograms or the MRIs, and that's where they track the brain and it sees impulses. The reality is, if you want to do a cognitive examination, you're probably not going to have those machines in your homes. The mini mental state examination is fine. You could do a mini mental state examination and you're probably going to come up with exactly the same thing. And then you've got your AUDIT, so the alcohol use disorder identification test. So that's the NICE Guide approved test for substance misuse. So if you've got a customer that's drinking alcohol in your service, I would always do that assessment, show that they don't have a problem, and then that's fine. Or alternatively, you could do that assessment if they are drinking and it may identify that they actually do have a problem, and you could put the right strategies in place. Because the reality is, sometimes what we perceive to be a safe level of alcohol isn't safe for that person. And what that risk assessment tool does is it tells you what is safe for that person. Yeah, because you know how in homes we'll go, oh, it's fine, Bert only has one at Christmas, or one here, or one there, or one here. That one actually to him could be harmful. So that's what that test does. Any questions on any of those? Have any of you heard of those or used those?
Yeah, we're using AVPU on early warning score, isn't it?
So the early warning scores is the must stuff. Yeah.
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 And we know about ABCD as well.
Yeah.
Haven't done alcohol use disorder, haven't got patients, so I haven't done that one.
Yeah, that's fine. And what about the mini mental state examination or the mental state examination?
Yes, because we are home with dementia, so we've got.
Have you seen them though?
No.
No. So from today, part of your own personal professional development is to go away and look for some of these tools, because some of these are life-changing tools. So when you've seen them and you've used them, you'll be like, wow, why have I never used that before? Because I can think of 12 arguments that I've had with somebody and they're telling me I'm wrong. You do this and you're like, there's the evidence, people. There's the evidence. And the mental state examination is perfect for that one. But remember, these slides are available, so that's okay. And you are expected to know the majority of these, not all off the top of your head, but you are expected to know that these tools exist because these are your assessment tools. So B, the BMI, oh Lord, to be honest with you, I've done nursing now for many years. I still can't do a BMI. I have to use the online calculators. You know, my thing is, it doesn't matter how you get there as long as you get there. So if you can work out BMI, obviously really important. Part of the muscle, working out BMI. So again, I always think the BMI scale seems to be slightly out of kilter because I've seen people the size of a matchstick and it says that they're overweight. And I'm like, wow, like if they lost any more weight, they'd fall down a drain. So there are different versions of the BMI. The one that I would use is the MUST BMI, because the MUST BMI is the clinical one. The Brandon scale, or formerly known as the Waterloo pressure scores, and then you've got your BUFALO assessment on there, and that's for your blood cultures, urine, output fluid, antibiotics, and oxygen levels. So that's a nursing form for maybe somebody where you're doing intravenous stuff. Finally, on there, you've got your BECS. So that's your depression scales. So that's now the GLAD-9 form. So the GLAD-9 is a series of questions in which you can ask somebody. It comes up with a score and it tells you their level of depression. So from low to severe. And let's not forget, people with dementia have underlying other mental health problems. The problem is the dementia always takes front and center. And what that means is things like depression is overlooked. Now, if you had dementia, I would think you probably would be depressed as well. Because part of your brain is going, I know this isn't right. So actually, if you were to do a BECS depression scale with people who are experiencing dementia, especially early stages of dementia, you would pick up, I am sure, that they have depression. And actually, we can treat that, we can alleviate that symptom and just make living with dementia a little bit more bearable. But again, could be another lovely research project. How many people with dementia have underlying mental health conditions that go undiagnosed? So that could be another lovely research project. Bed rail assessments. So if you've got bed cots, I'm sure you all know you must do a bed rail assessment. When can you not use bedside rails?
It comes under DOS, is the prevention of liberty safeguarding. So we have to assess if it's, yeah.
Yeah, absolutely. So it is a DOLS. We are depriving people of movement. If we use bed rails, they have to have cognitive understanding, because if they don't, it could be a hazard. So we would never use bed rails on somebody with a cognitive impairment, because if they had a cognitive impairment, it is a risk. And I have dealt with a safeguarding. I was a safeguarding officer for a gentleman who snapped his neck and died getting out of bed. So he had late stage dementia, his leg got caught, he went head first, snapped his neck and instantly died. So it is so important that if somebody says to you, put the bed rails up, or you say, put the bed rails up, you have done a bed rail assessment. Because if not, and you're worried, put the bed to the floor, put a mattress on the floor, just get the person to the floor, do not use bed rails, okay? Any questions on B? And I think most of you will have seen these ones, right? So moving on then to C, catheter assessment. So have any of you got catheters in your care home?
Yes.
Do you use catheter assessments? Probably not. Lots of people have them, but they don't use them. So a catheter assessment looks at the fact that should the person A be catheterized in the first place? It looks at how long should we be catheterizing somebody for? It checks about how long we should be using them, how often they should be changed, how frequently they should be flushed. So a catheter assessment is really important. If you've got somebody with a catheter, it is really important that in the care plan, you have a catheter assessment. And that's because the longer we use catheters, the more likely it is that the bladder will just stop working. Those muscles in the bladder that contract and hold the urine just end up giving up. So the longer we keep a catheter in somebody, the worse it is for them. So they should really only ever be used for short-term activities. And there should be real justification if you are going to catheterize somebody. Okay. The Cuban injections, pressure ulcer risk. So this is looking at leg ulcers and pressure ulcers. So again, a really good one. If you've got customers with pressure sores, you can do the Cuban and Jackson assessments on those. Again, comes up with a tick list, gives you a score, and it gives you an idea on the risk of that ulcer. So what it will say to you is the level of the ulcer and the integrity of the ulcer. So is this ulcer going to get significantly worse? So that score is really, it's a useful one if you've got patients with ulcers. The confusion assessment method identifies symptoms of confusion or delirium. And we know that delirium is maybe a fleeting thing. So a confusion assessment tool might be really useful for when you've got those patients who you think are early stages of dementia, but everyone's going, no, it's not dementia. Because you know, when you've got those customers and you're going dementia and everyone's going, no, it's not. So the confusion assessment method is really useful because actually what you're saying is, well, look, even if it's not dementia, this is what we're faced with. This is the score and this is the risk. But what we tend to have is that back and forward, it's not that, okay? The CAM-ICU, again, looks at confusion assessment tool using the intensive care units for patients. So that tool looks at the intensive care unit side about the choices that people are making if they're not well or maybe end of life there. Looking at the centre score, looking at criteria, the likelihood of bacterial infections around sore throats. So that's if we're using airways or suctions. So if you're using a suction machine or you're putting anything in people's airways, it's really important that you do a centre score assessment because you're identifying risks of throat infections, bacterial stuff, Staphylococcus aureus, bacteria, and sepsis. So they're really important. If you're going to put things in people's mouths, that's where you need to be. And the CRE assessment, again, it's a screening tool. So again, looking at other bacterial stuff. So a little bit of nursey stuff in there. Have any of you used any of those? Or is that new to you, those ones?
No, it is new for me. I haven't used it.
Good. And actually, what's nice for you, after this, you can print this out and identify all of these tools and just put them in a folder. And if you needed to use them, they're there, aren't they? Because actually, what's really nice is as you're a level 5 assistant practitioner, your clinical judgment is all going to be evidence-based. You don't have to say anything. Did you want to say something, Karina?
Yeah, how often do we have to do this assessments? Like once a year or?
So each tool will tell you, each tool has a different time frame. So one will say review in 6 weeks, one will say review in 6 months, and it depends on the score of each tool. So again, clinical based, not you. You don't have to make up and say, oh, this is what I said. They're all evidence-based with their own frameworks. So the DISDAT looks at helping to identify distress cues. So again, that's looking, this is perfect for dementia, this one. So this assessment tool is perfect for people that can't tell you that they're in pain. And what it will do, it will come up with a score and it will give you a justification to give a PRN medication. So let's say we've got Mary in bed, she can't talk to you, she can't communicate. You think she's in pain, but that doesn't look so good on a care plan. Gave PRN because I thought she was in pain. If you did this, did the DIS score, this is what it was, this is what I gave, the morphine or the paracetamol, whatever it is you gave. Yeah. So again, perfect for those people that can't speak. Early warnings, I know someone's just mentioned that. We all know about early warning scores, the Muse, News or Pews. So the Muse and News are roughly the same thing. Pews are pediatric early warning scores. And actually what we're doing here, we're looking at the physiological well-being of everybody. We're looking at heart rate, oxygen levels, blood pressure, pulse and temperature, and we come up with a score. And from that score, we come up with our clinical intervention. This is the one that I think will be in your endpoint exam.
Mm.
So you will do an assessment and then you have to do the justification, because it's what I've heard, but they may change it because you're going to be 18 months from that. But anyway, that's what it is. Each service should be able to do a news score, and you will further down, we will do vital signs, and that will be one of the things that obviously I'll come out and observe you do, because you must be able to do all of that. F, we're looking at the FAST, so that's the stroke-like symptoms, the face-arm speech test, the falls risk assessment tool. So if you've got customers that have got a history of falling, or maybe you're concerned about the falling, you must have a falls assessment tool. There is a course in which you can do, it's a free course. I can give you a link to it if you're interested, but it's all about falls preventions in care homes. And the reality is, they are preventable. So if somebody does fall over, and what we're saying in here is, if you've got a customer or a service user that you identify at risk of falls, you can get hip pads, hip protectors. And again, if you know, we can stop those fractures and stop them deteriorate. We've got our FRAX tool, looking at fracture risks. So again, if you've got somebody who's at risk of falls, I would then do the FRAX tool assessment, because it would tell you the likelihood of a fracture from that fall. Equally, if you've got somebody who's osteoarthritis or got any of those rhitises, you know, rheumatoid or any of those, I would do the FRAX assessment, because actually it gives you an idea on the risk of the fracture and the severity of the fracture that they would get. Okay. And then obviously the last one, the FLACC, which is face, legs, activity, crying, looks at behavioural assessment tools designed for paediatric and non-verbal patients. So again, this one at the bottom is ideal for your patients with dementia, because again, if they're non-verbal, you can do this assessment and you can pick up a lot of stuff about what's going on there. Moving on to G, we've got the Glasgow Coma Scale, so that's levels of unconsciousness, point-based system. We've got the Glasgow Depression Scale, point-based system for somebody that's obviously got depression. You've got the GRACE score, it's a risk assessment, looking at acute coronary syndrome, and then you've got the anxiety depression, the GLAD-7. So again, people experiencing anxiety. And what you tend to find, most people that go into a care home environment will score quite highly on a GLAD-7 score in the first week of them being in a care home. Because again, it's a new environment. Will I make friends? Will I settle in? Will I be okay? So if you did a GLAD score on admission, you will probably find that this will be quite high. And actually, it gives you an idea then about that level of vulnerability of that person when they're coming to you for the first time. Equally, you may have a member of staff that you're working with and you constantly see that they're struggling. It's useful to use these with peers and just give them as a self-assessment tool to say, look, maybe you need to deal with this, because actually the last year has been quite hard on care staff. And they may not recognise that they're depressed, and they may not recognise that they've got an anxiety disorder. You may know it, and what you could say is, look, here's a self-assessment tool. And those tools you can do online or they're paper-based. But again, all really good. And especially if you wanted to get medication to help somebody with anxiety or depression, then you would normally ring your doctor up and say, look, doctor, Clara's got a score of 14 on her depression scale. It's quite severe, and he would give you probably fluoxetine 40 milligrams or something, because he will understand what that assessment tool is and what it does. So by using recognised tools, you'll get medication for your patients a lot quicker. Yeah, happy with that? Any questions on G? No? Marvellous. Right, H, hourly rounding. So this is where we should be doing, especially in dementia units, or children or people with delirium. So this is where we do hourly observations. And hourly rounding is where we do head counts every hour to make sure that, especially for an open ward or a residential home that's got an open door policy, we should be doing hourly roundings, because it will tell you the last time that they were seen and within that last hour. Equally, hourly rounding is about the last time you saw them breathing. So at night, hourly rounding is really important, because when somebody dies, there's nothing worse when the coroner comes and they go, they died 9 hours ago. And then the carers go, but I saw them only the last 2 hours and I signed the chart. Hourly rounding looks at, have you found the patient and are they breathing? And that's really good evidence. Okay. Hospital anxiety depression scores, you probably won't use those, but you could use those in your care homes. So again, this just looks at their psychological and mental state. And the H's and T's looks at different areas of cardiac arrest. So again, if you've got people with maybe strokes in the past or cardiac problems or previous hearts, you could do a H&T assessment and it'll tell you the risk of them having another heart attack or stroke, and then the types of things that you could do to avoid that. The Liverpool University Neuropathic Side Effect Rating Scale is a self-assessment tool measuring side effects of antipsychotic medications. So again, this is the dementia homes as well. So this one looks at the effects of the medication on the person, because the reality is some of the medication in which we give to our patients, the side effects do not outweigh the benefits of the medication. And therefore, we should be observing them on a regular basis to say, look, the medication that's being prescribed, especially antipsychotics, especially things such as risperidone, some of the SSRIs, looking at some of the like haloperidol and those types of medications, the side effects can be quite aggressive. They can cause hallucinations. They can cause people to scream. They can, they can make people feel more suicidal. They can cause severe depression. Like some of these side effects are much worse than what the medication is trying to do. By using this side effect rating scale, we can see, does this medication actually have a therapeutic benefit or not? And ultimately, if we are going to prescribe a medication which is life-limiting between 15 and 25 years, we should be able to justify it. So a lot of the antipsychotic medication which is given to patients could be life-limiting up to 25 years, which when you think about that, that is a nasty side effect of a medication. And if somebody said to you, would you take this medication, but it'll reduce your life expectancy for 25 years, would you want to take it? Probably not. No. So actually, we need to have this understanding in healthcare that if I'm going to give you this tablet, especially something like haloperidol, and it's life limited between 15 and 25 years, is that worth you taking it? You know, where's the justification? So this gives you that justification. And again, for patients with dementia, looking at some of those medications looks at, is it worth it? Is it not worth it? Finally, moving on to the M's, the must, we've already looked at the must scores. We understand that's malnutrition, dehydration. And again, that's common in all care homes and all nursing homes. Do you all use the must score?
Always.
Always, good. So again, should be done on admission. So if you're in a hospital setting, you would do a must score straight away. And equally, if they come to you straight away, must score it, because only then can you start to track up and down. So the mini PAS ADD is an assessment tool for undertaking mental health assessments with people with learning disabilities. Again, new phenomenon coming through, isn't it? So in care homes now, we're starting to get people with learning disabilities because we're living longer. You know, we've got people with learning disabilities who are now experiencing dementia. And the problem we're getting is we don't know where to place them. Do we keep them in a learning disability home, or do we take them out of the learning disability home and put them in a nursing home for dementia care? What do we think? So we've got, let's say we've got somebody with Down syndrome, they're now 60, they've had learning disability, they've lived in a learning disability home their whole life, they've now got dementia. Where would we put them?
In a nursing home, I think.
So you're going to take them out of their home and put them in a nursing home? Anyone else agree or disagree?
No.
I think they should be on a learning disabilities home, but we do have in our home recently one patient with learning disabilities. So I think they're trying to bring them. I don't know exactly the reason for which they do that.
And I can tell you why the reason they're doing it is because it's new. We don't know what to do. It's
All right.
a brand new phenomenon in nursing, because people with learning disabilities do not typically live over the age of 50, especially into the age of 60. And they are now, because we're living longer, we're being able to treat people more. The problem is it puts a real ethical dilemma out there, doesn't it? Where do we now treat them for the best place? And who is the best person to look after them? Is it a learning disability service, or is it a dementia service? So again, another good research project there. How do we look after our aging population with learning disabilities? So if you've got one in your service, that could be a real thought-provoking topic. Perfect. And again, so the mini PAS ADD then, Clara, for you would be a great assessment tool because you have people with learning disabilities in your service. Moving handle assessments, I hope you all do those anyway. There is a real bone of contention with this. Out in the community, occupational therapy do them, residential homes, nursing homes, we do them. You try and explain that to an occupational therapist that we have to do our own assessments. They tend to not like it. But we use the same assessment tools, don't we? So the reality is we should be doing those and you should have those. And the MRSA is the assessment, obviously, for the Staphylococcus aureus bacteria, which generally is the bacteria up the nose. And we start to look at things like the risk of that spreading. Marvellous. N, we're looking at the pain sedation score, normally for intensive care, but looking at using body language and verbal responses. So the NPAS score is what you can use for end of life care. So if you've got somebody who's end of life, then the NPAS score is what you need, because actually you are going to be delivering, probably via a syringe drive, the end of life medication. And therefore you'll need a score to justify why you're administering the sedation at that level. Okay, and the NPAS score does that. Has any of you done, or any of you end of life in your homes?
We have, but obviously district nurses is the one dealing with the.
So they do at the moment. However, you may get to a point where you become a gold standards framework home, and you become an end of life specialist, because actually there's a lot of money in that from a business point of view. And we can do, you're going to do syringe drive training as part of this course. so you'll know how to use the syringe drive. It's one of the assessments that you have. It's one of the last ones, actually. So the MPAS score is really important because actually, as assistant practitioners, you should know how to assess a patient and how to get that medication for into life and how to set up a syringe drive. So we're going to show that in this course anyway. But obviously, you're going to back that up with the MPAS score. We don't need to know that one. We're not going to be doing that one. Two-stage capacity test. So this is around obviously capacity. We know about the capacity assessments. You've been doing this since 2005. So this is about making sure that somebody has capacity and can make an informed choice, and they're able to weigh up the rights and the decisions which they're making. The traffic light assessment looks at children learning difficulties, and it's just a way of helping people to communicate. Thrombosis assessment, VTE, so deep vein thrombosis. If you've got patients which are slightly overweight, maybe they've got edemas, lots of swelling on the legs, lots of veins going on, should do a VTE assessment or a DVT assessment, because again, it'll identify whether or not you should be doing compressions or elevations and whatever to help support them. So if you have got patients probably more prone to dementia, because those that are walking with a purpose can end up with quite swollen ankles and VTEs and DVTs. So again, if you have a customer, a service user that does go around walking, the VTA assessment or the VDT assessment is the perfect score, because again, if you're saying to somebody, I need you to sit down and rest, you've got the clinical judgment why. You know, this is causing you a cardiac problem, it's causing your veins to swell or collapse or whatever, and this is the score, this is why we need you to sit down. Because people will now argue with you, oh no, she's got a right to walk around. She does, but equally there is a risk if she does it, and this is the risk. So we're looking at safer nursing care tools. And again, they just look at the staffing levels. So the staffing level dependency, this one, again, is very controversial, but it's what we use to know the right amount of staff to the right patient. So the safer nursing care tool basically gives you an idea on staffing levels. Very useful if you're a care manager. If you're the homeowner, you probably won't want to know this tool because everyone's like, oh, but the reality is it looks at the amount of time it takes to care for somebody. So if CQC says to you, why have you only got 4 staff on? You can say, well, our safe nursing care tool says this is the amount we need. And you know, when you've had those carers on shift going, oh, we've not got enough staff, or we've not got enough staff, or we've not got enough staff, and you're like, we have enough staff. Then you can say, look, this is why. Okay. SABAR, again, you'll do in vital signs. SABAR is situation, background assessment and recommendations. So this is you, after you have done your assessment, you will do a SABAR. Okay, so this is relevant to all of you. If you do an assessment on a patient, you will always finish. So your logging off involves a SABAR. And the SABAR is you passing that information on. So if you're going to pass this on to a doctor, if you're going to pass it on to a nurse or a manager, you're going to say, look, this is the situation. Here's the background to that. This is what I did. This was my examination, observation, whatever it is. The assessment, these are the tools that I used. And off the back of these tools, here are my recommendations. Yeah, does that make sense? So for example, you may have somebody who's low in mood, got anxiety or depression, and you go, look, met Sue today, did her GLAD score, it was really high. I recommend that she has a serotonin inhibitor uptake, so an antipsychotic to help with her mood. Situation, background assessment and recommendation. It is your recommendation. So at level 5, you absolutely can recommend treatment plans. You can recommend, this is what I think this patient should have. Okay, they don't have to listen to you, but you absolutely have the right to recommend it because you're going to be using the right assessment tools for that. The SPIT tool, the Supervision Palliative Care Indicator tool. So looking at end-of-life care, if you do have patients that are end-of-life care, you can use that and it'll come up with that they are or they're not. And the last one here, again, the SOCR RAT tool is an acronym used for professionals to evaluate the nature of pain, what a patient experience. So it's the site, onset, characteristics, associations, time, relevant factors, and severity. So again, that's an observational. So if you're looking at pain and somebody says to you, I'm in pain, you could do your SORATES score or assessment, and it justifies why you've given PRN. Because when we give a PRN, we have to justify it, don't we? We can't just give paracetamol because it's a PRN. We have to say, I gave this because they were in pain. You have to justify why they were in pain. So if, again, they can't tell you, you could use that score, that assessment, and you could say, look, I could see that they were holding their arm. This has been coming on for a bit of time. It's the characters are, you know, I could see the wincing on the face. I could see them screwing their thing up. They were holding the area. And again, you could do a pain scale chart or whatever for the severity of it. So again, just justifies why you've said what you've said. We're looking at the Richmond scale. So again, it's looking at sedation and it's looking at pain and discomfort. So again, just another one to determine the level of sedation in which you need to give. So if you are looking at end-of-life medication, or even if you do respite and you've had people from hospital and they come out. So I don't know if any of you do the respite care, because I know care homes were being used for theatre discharges, weren't they? Where they come to you and recover. Have any of you done those?
Yes, always.
Yeah. So again, if you have got somebody coming out of surgery and they're coming to you, the RAS score is really useful because you may be saying, look, that medication isn't strong enough. I can see they are in pain still. And I've seen some really wicked things come out of surgery where they've just given people paracetamol. And I'm like, well, surely they need at least a codeine or a morphine for a day or two just to get them off of that. And they're not doing it because actually the therapeutic benefit doesn't benefit them, but we all heal differently. So again, we may need to justify why we think somebody needs a stronger pain relief. Moving into W, we've got our Waterlow scores. We all know those ones, prediction pressure sores. The WHO checklist is designed to reinforce safety procedures, foster better communication and teamwork. So that one's useful if you're in a situation where you need to look at things around clinical decisions, patient confirming identity, consent, all that stuff. So all the communication stuff, it's a really useful checklist. And it just runs through like clinical procedures on how you get stuff. The Wong and Barker face pain scale. So again, this is the one where you've got all those little faces from sad to happy. So really useful for somebody that can't talk. They can just point. They can do that one. The Wells criteria, deep vein thrombosis, so another VTE. You don't have to use two, you can just pick one, but they are on the approved list. Visual infusion scores. So this is about if we're using IVs and infusions, and it's to do with signs of infection. So it looks at when the cannula's going in, how long you're going to change it, how to reduce any kind of risk of sepsis, etc. So we've got that one. Mini mental state examination, we've already covered. The GLAD score, oh, these are the mental health ones. Okay, so they were all your physical health, these are the mental health ones. So the mental state examinations, obviously for mental health, we've covered that one. And actually you can see on there, what it covers is, it looks at the state of mind, it looks at their attitude, their behavior, their mood, the effect, their speech, their thought process, their thought content, perception, cognition, insights, and judgment. So that's what it looks at. When you actually do the score, when you actually do the assessment, it gives you a definition of what each of those are, so what you're looking for, and it gives you a scale of 1 to 10 for you to grade it, if you're doing a grading one. If not, you're just expected to write a statement under each of those on why you've deemed it to be with or without. GLAD score and pH score, we've already spoken about already. don't need to worry about that. Suicide and self-harm. So if you've got somebody that is suicidal or they're self-harming, we do not use an assessment tool. There are no approved assessment tools for patients that say they want to kill themselves or they want to harm themselves. Okay. If you have a patient that wants to harm themselves or they're saying they're going to kill themselves, you must do a clinical interview. Okay, so you would do the date, the interview, what you observed. So you would do a mental state examination and you would come up with a risk. So off the back of what you have observed, do you believe this person to be at risk or not? Okay, now suicide and self-harm is quite a complex subject. Further down in your training, there is a training module on each, so it will make more sense further down. But at this point, NICE guidelines make it very clear there are no approved assessment tools. You will hear people saying there is, but there's not. Okay, so please don't use any, because the reality is we can't possibly judge somebody using a piece of paper on whether or not they're going to kill themselves. Somebody needs to be heard and they need to talk. And from that, you decide, does it sound like they're going to do it or are they just letting off steam? Okay. OCD, so obsessive compulsive disorders. So again, there's not many approved assessment tools for mental health patients, and that's because it's so fluid. There are so many different reasons why people may or may not be doing something. So again, we use an observation assessment. So how clean are things? How often do they check it? What is bothering them? What takes them a long time to do? Why do they do things in a specific order? And do they have problems? That trouble you? So here, it's another clinical interview. Why do you think that in mental health, we don't have many assessment tools versus physical health? Why do we think that mental health is all about observation? Why do we think there's a...
Because this is how we collect the data for...
Absolutely, it's how we collect data. But my question is, why do we collect data in a very different way to physical health nursing? So in physical health nursing, you've got a checklist or a risk assessment or a tool for everything. When you hit mental health, it very much is observe, ask questions, observe, ask questions, observe, ask questions. Why do we think there is such a difference in the two fields? Does anyone want to have a guess?
Is it because behavior varies?
It is to do with behavior. Yeah, it is to do with behavior. Does anyone want to work on that? It's really interesting. And again, you all work across both fields, don't you? You all have customers physical health and you all have customers with mental health. So the reason is quite simple. Under mental health, it's just not as simple as a broken arm. A broken arm, we know takes about 6 weeks to heal. We know what the signs and symptoms are. We have enough data to analyze that. A wound, we know what a wound is. We know how long it takes to heal. We know the factors that can do that. So we can score all of that. The problem with mental health is we just don't know. Too many factors underneath it, too many sliding factors. Each of us have different protective characteristics. So we all have a different reason of why we get up in the morning. We all have different reasons why we're alive. It's just so complex. So what keeps us safe, what we think should keep us safe, may not keep somebody else safe. So therefore, you could never put that in an assessment tool. It's just too vast and too wide. But what we can do is we can observe that behavior. And that behavior, is that normal? Is that what we're looking at as a socially acceptable thing? So if we were doing that mental state examination, are you talking? Does it make sense? Do you look well dressed? Are you caring for yourself? So with OCD, do you clean your worktops 15 times in an hour? I don't. I do have an OCD problem, but I don't have an OCD diagnosis. because we all go in nursing. I think all of us have been responsible to go, I've got OCD, I've definitely got OCD, got to wash my hands, got to clean those worktops. The reality is, are you compelled to do it? I do it because I think, oh no, it's time to clean it, or I'm just about to do something. So actually we have to weigh up. So in mental health, we have to weigh everything up. We have to weigh up why the person's doing what they're doing. What's the history behind it? You know, what's their thoughts? What's their feelings? What's their behavior? Is this normal for them? Is this not normal for them? And you could never come up with an assessment tool like that. And that's why a lot of the stuff in mental health, you will always have a clinical questionnaire to ask. And then from that, we take the data. So if we think about the two methods of nursing, so in nursing, in adult nursing, it's pretty much done on charts and numbers, and a number gives you a score, and that score gives you an outcome. In mental health, we tend to ask questions and we look for a theme. Yeah, does that make sense? So across the two, if we look at our evidence-based, if we look at our research projects and we look at assessment data gathering tools, what would they be classed as under data gathering tools? So if I'm using charts and numbers as a data gathering tool, what would that be as an evidence in research? So as a research method. I'll help you out. Is it quantitative or qualitative? So for nursing, we
Qualitative, probably.
qualitative. Anyone else? So if we're going to do numbers, it's quantitative. Quantitative as in a number. Quantitative, how many? Qualitative means I'm going to find a theme in something. So when you do your research project, you might use nursing as an example and use charts and graphs and numbers. That's qualitative. So quantitative. Quantity, yeah, we're going to add it up. Qualitative, however, is very much what we do in mental health. We look for themes. So we're looking for common themes and common goals or common behaviors. And when something falls outside that common behavior, that's when it gets a diagnosis. Happy with that? It's quite a lot to take in. I get it on a Wednesday at this time in the morning, but it's there for the future. Finally, the addiction test. So many addictions now out there, isn't there? Obviously, if you've got people there, you can do an addictive test. Lots of different types of addiction tests out there. There's addiction tests for alcohol, addiction tests for drugs and substances, one for smoking, one for gambling, one for gaming. Gaming is now one of the highest addictions we have in the UK. So children are now becoming severely ill through gaming. And that's because they're spending large quantities of time online and they're not getting their exercise and their daylight, and it's becoming a real problem for CAMHS. What do we think we can classify an addiction as in nursing? So rather than me going, you're an alcoholic because, I would go, you've got an addiction because, what would it be? Okay, let's try this one. If I finish my night shift and I get home and I have a glass of wine in the morning, am I an alcoholic because I've had a glass of wine?
No.
No, because we've all done that, right? We've all done a night shift, gone home, had a glass of wine and gone, oh no, I'm an alcoholic. Okay, so we've decided just because you get up in the morning and have a glass of wine doesn't make you an alcoholic, just makes you a nighttime drinker in the morning. So what would make me an alcoholic?
If you do it more often and in a good, a lot. So if you have a lot of big quantity of alcohol.
Okay, but then what would be a large quantity of alcohol? Because I guarantee my intake would be very, I don't know, I can't guarantee that. It could be very different to yours.
I don't know, a lot of liters.
So we bring it to work in your flask. Yeah. Okay, so an addictive personality or somebody with an addiction, if we summarize it as I'm going to tell you, I hope it makes sense. It is evidence-based, what I'm going to tell you. You can find this, but it's just a useful framework. Okay, so somebody with an addiction problem is somebody who prioritizes that above everything else. Okay, so I need that drink, that's my first priority, or I want to go on my computer, that's my priority, or I need a cigarette, that's my first priority. So if somebody cannot prioritize beyond what that addictive part is, drink, drugs, alcohol, sex, whatever it is, that's a sign. The second sign is, does it cause them financial hardship or distress? So are you prioritizing your money to that problem over anything else? So for example, you may have somebody who spent all of their shopping money on alcohol or cigarettes and hasn't bought any food or paid the bills. So they've prioritized that substance above their normal priorities. And the third point is, does your behavior affect the relationships and people around you? So the reality is, if you say yes to those three things, it is likely that you have an addiction of some kind. And what we tend to find with addictions is they normally have more than one. And you may have heard the phrase that some people have an addictive personality. So they tend to get hooked on things quite quickly and it becomes a bit of a compulsive thing. So again, they may have an addiction plus a bit of OCD going on because they're obsessed with whatever there is. But what we don't do is say, just because I got up this morning and had a bottle of wine makes me an alcoholic, because it doesn't sound great. But if I'd done a night shift and that's my morning, then it seems okay at that point, right? Especially if it's only one bottle of wine and it doesn't affect anything else. And the reality is, what we did over the years, we normalized behavior against social norms, and those social norms were Monday to Friday, 9 to 5. So as long as you acted appropriately within that time, you know, if you were drinking between that time, it was seen as an out of the ordinary. What it didn't do is it didn't take into account the fact that we are now 24 hours a day, 7 days a week working. So the reality is, we can't judge people just by what they tell us. We have to dig a little deeper. Yeah. However, those three things, if you're prioritizing this above everything else, if it's causing you financial distress because you are prioritizing that, and it is affecting your relationship, so it doesn't say what a relationship is, it could be work, it could be family, it could be friends, then you are likely to have an addiction. Okay, but we don't call people alcoholics anymore. We don't call people drug users. It's, you can have an addiction or a substance misuse. Yeah, so you can be a substance misuse person, or you can have an addiction, but we don't label, because labeling is not helpful. Happy with that? You're all sitting there going, I wonder if I've got any of that. Tick, tick, tick. Right, we're not here doing you guys, that's fine. Okay, so that's the end of that session. That brings us nicely on to 11:30, where I wanted us to have our first break. Does anybody have any questions? I appreciate that assessment is quite a lot. That was quite a big session, wasn't it?
Mm.
Any questions on assessment tools, or are we quite happy?
Yes, I want to know where we can find those tools. Can we find on the internet, or where can we find it?
Yeah, so what I'm going to do, this is all uploaded into Canvas. So after today, the video is going to be uploaded, and I'll do a link to where you will find most of those tools, because I've got most of them. I've put them in an external drive. If you click on that link, it'll take you to lots of different assessment tools. And obviously, if it's not there, you can just Google them and research them. Because remember, if you bring an assessment tool into your place of work, it must go through some level of clinical governance. So talk to your managers, talk to your nurses and go, look. So the list that I have shown you today is the approved NMC list of assessment tools. Okay?
Are these all of them, or?
That's the majority of them. There may be an odd one or two sneaking around in the background, because obviously it's evidence-based, they change and update all the time, but that's the majority of the assessment tools that would help you form an assessment on a patient. And this is why, hopefully what you've seen is, you could never go in with all the right tools. You need to do that clinical interview first. Hi, I'm Steve. We're going to have a little chat today. Just tell me about yourself. Why are you here? And in the back of your head, you're going to be going, oh, I need that tool, I need that tool, I need that tool, I need that tool. Next time we meet, you'll have all of those tools ready for that assessment, won't you? Yeah. So we always start off with a clinical interview, get the information, and then we're ready to go. Some of you may get that clinical information already. It may come via the council. You know, you may get lots of data. It's my experience that when you get that stuff, it's not right. You normally have to do your own assessment anyway, because normally what you get told is not what the person is when they're being presented to you. Okay, so shall we take a 15-minute break and we all get back for 11:45? Is that okay? Just turn your cameras off. You don't need to log off. Just turn your cameras off.
Can we log off? Because I'm on my phone.
Yeah. Log off as long as you log back on for 11:45.
Yeah, okay.
Take care. Bye, everyone.